This episode of Simulation Nation is brought to you by Avkin, your one-stop shop for everything wearable simulator and standardized patient.
Hello, everybody, and welcome to Simulation Nation. Today, we are going to talk more about modalities and when to choose different modalities for your simulations.
Yeah, and I think that, a lot of people kind of pin us as the hybrid simulation with wearable simulators and SPs, which is definitely where our sweet spot is. Mm-hmm. But we have had experience with others or talked to a lot of people that are using different modalities. And just want to kind of share with you, from the body of information that we have to help you make better decisions as you are trying to decide what simulation is next and what are your objectives, and then what modality is going to go along with that as you design your sims.
Yeah, and I think also just creative ways of being able to use different modalities. I think that there's a lot of different concepts of how people have used hybrid simulation beyond just standardized patients and task trainers or standardized patients and wearable simulators. And I think that there's a lot of different ways of being able to incorporate it that are very unique and creative to meet the objectives of the simulation.
Yeah, and we did some really cool and creative things when we were doing simulation on a full-time basis. So we can talk about those too.
Yeah. So to start off, I go back to this conversation that I had I guess it was a few years ago now. And I remember having a consultant who came up and she was working a lot with standardized patients. And she started talking to me kind of about different modalities or different concepts. And she said, what are your thoughts? What are your feelings on these different modalities? And my response was...
It was a test.
Well, my response was that there's a time and place, right? There's a reason why these different modalities have come up. There's different reasons why these, products are emerging into the market. And her response was, well, as a standardized patient, because again, that's my background, you don't hate other modalities. And I was like, no, because standardized patients are not always going to be the solution. And I think sometimes the mindset is that if you especially come from that background, that it's like, well, it is the only answer. You design your sims around it. This is how you need to do it. And I think that there is a bad rep for standardized patients that they feel like their job is in danger by now diversifying the modalities of simulation. And I would like to have it where everyone kind of has that open mind in terms of what are the best options for the objectives and for the simulations, when you're in that design concept.
Yeah, and I mean, I think if you look at like you said, there are things that have emerged in simulation since I started in 2006. Yeah. And they have come out of a need. We're trying to fill a niche, right? With all things considered, when you think about environmental fidelity and wanting to make this as closely applied to the clinical experience that they are going to have, there's times and places for everything. Yeah. And I think it's really important that as you're considering your simulations, you are including the fact that it's not a one size fits all. Yeah. As far as simulation goes.
Yeah. And recently when we were talking at Sam Houston, when I did a presentation on the different modalities, how I equated it, and I think that it's a good analogy, is just what are the tools in your tool belt? And some sim centers are going to have a lot of tools in their tool belt and a lot of ways that they can use, a lot of different creative ways. And some people are going to be more limited. They're going to have more basic tools in their tool belt. And I think that the important part is, as simulationists, we can get very creative with what the objectives are and making sure that the simulation has that environmental fidelity. But what I would caution a lot of people is, if you don't have the right tool in your tool belt, you might need to rethink that simulation. Yeah. Before just being like, this is the sim, I will make it work. You're going to lack some of that environmental fidelity. And again, you're probably then going to get feedback from your students about, maybe some inconsistencies, maybe some trouble with that. And my suggestion would be, before you jump into that sim, make sure you have the appropriate tools to be able to accomplish those objectives in that simulation the way you want it to.
Yeah, and I think, again, like when you say that, I think of the time that we had the meds in the room with, for the sim. The meds were like at the the sink area. And what we got feedback from the clinical instructors was that the students were taking the meds in clinical, now in the hospital setting, and taking them into the room and leaving them there. And that's just, you're not supposed to do that ever. So we were actually having to rethink how we had our meds, the accessibility of the meds, and were we reinforcing that, were we using that same thing? So though has nothing to do with modalities, it does have the same concept of that you always have to be getting feedback from subject matter experts. And it doesn't mean that you can't hit the objectives with a different approach, but it does mean that you have to consider that in your design, right?
So what I thought of when I was thinking about this was in past years, this was a long time ago, but when they were doing a maternity simulation and wanted to add in some people from diverse backgrounds. And the concept was, we're going to have this mom have done cocaine before she came into simulation. And at the time, they were only using mannequins for that sim. Well, I don't know how 1 + 1 = 2. I don't know how they got to this place, but the concept was, we'll just put some white powder under the mannequin's nose, on their upper lip, to show that they had done cocaine before they came in. That's how we're going to meet that objective. And that to me is one of the biggest, they didn't have the ability to have a standardized patient or someone in the room who could properly represent this patient.
The physiological responses.
But they also wanted to include this diversity element into the sim. So they didn't have any other way of doing it other than something that really is not environmentally correct. You're never going to, I shouldn't say never, but it's highly unlikely anyone's going to walk in, be birthing a baby with cocaine still under their nose.
I mean, and I think the other caution to that is that furthering the stereotypes,
exactly,
right? Where,
yes.
The students are expecting that if they have no experience with this in their own personal lives, which probably most of them don't, that they're going to walk in, if somebody has been doing drugs, that there would be white powder under their nose, which leads people in the wrong direction. So
what were your clues that this person was doing drugs? They had white powder still under there was still residue there. That was my only indication to understand that that's the patient population we were trying to represent there.
Right. Yeah.
But I think that those are the concepts of when simulation can go wrong in terms of that environmental fidelity, or simply not using the tools that you have to create, to meet the objectives that you're trying to. And I think that it's always going in with good intentions, but I do think sometimes we can get tunnel vision. And I think that in that simulationist mind, the mindset was, I have a mannequin, I want to include this as the objective. How do I get there? All right, this is how I get there. And rather than bringing in subject matter experts or people who are objective into the scenario to say, is this a good idea? I think sometimes we just keep moving forward.
Yeah, and I think, again, from the mindset of a simulationist, you're in that situation, and it wasn't me, so I can't speak to it. I'm an ER nurse. I am not anything maternal child whatsoever. But you do the best you can with what you have. And sometimes you're just being asked to accept that this is the only tool in your tool belt. And so you do your best. But in some situations, like I said, it can lead to being misleading. So let's talk for a second about, do you want to start with task trainers and kind of move our way up?
Sure.
Okay. So we actually wrote in Defining Excellence in Simulation, the second version.
Volume 2.
Volume 2. No. Is it Volume 2? No. Yeah. It would be, I don't know, Publication 2, whatever.
Okay, Publication 2. I'll call it Volume 2. I like that better.
They asked us to write a chapter on task trainers. So we started with really kind of the static, task trainers that are typically used in skills and simulation, and worked our way up because they become more sophisticated. Unfortunately, in our opinion, they didn't have a whole chapter on wearable simulators, but we were able to really define out the difference between adding technology into these body parts that, really make the authenticity and the physiology appropriate. So from the perspective of task trainers, what were some of the things that you talked about in your presentation at Sam Houston?
So we discussed more in terms of using them for a hybrid concept inside of simulation. So we're not really going to touch too much on skills, just because I think that then that opens up a whole nother avenue to discuss. But in terms of simulation, being able to use it where it could potentially be on a table, where students are moved over from, the mannequin or the standardized patient over to a tabletop to complete the skill that they're expected to do during sim. So either that's starting an IV, it could be doing, a suture, whatever it is. Or the concept of actually having it where it is in bed with that mannequin or the standardized patient to almost act as an additional, they'll hide one limb to make the new arm that limb and things
like put it inside the hospital gown or something.
Yeah, to kind of to try to mitigate that. And I think the main benefits with that, number one, is it's cost effective. So being able to use various task trainers inside of simulation, it definitely helps with being able to maintain some of the wear and tear that can come with mannequins in terms of sticking them with IVs or needing to get them reskinned, things along those lines. It does help with kind of that logistical purpose. It also does help in terms of setup and takedown, because needing to put the fluidics inside of the mannequin and be refilling those fluidics, especially if you think about urinary catheterization and things like that, it is not an easy process to go back in and keep refilling that, especially when you have a lot of students going through. And in sim, typically they are draining the full bladder, so then you have to go back in and put in a whole nother amount of...
If I'm honest, the problem with that, with mannequins, with putting the urinary catheter in is because there's no pressure on the bladder, the catheter goes in, and then because it's rubber, it essentially floats to the top. Mm-hmm. And then you only get a small amount of urine flow, maybe 100 cc's. But if you wanted to actually put 400 milliliters in to the bag of urine so they could see that, hey, there was some urinary retention, or, they did a bladder scan and, so all of those things, there's limitations within that.
But it does help when you have the task trainer to just, again, reduce the need for needing to go in and reset that every single sim. That typically with that task trainer, it's going to be a lot easier to just kind of, because they're built for skills, right? They're built for repeated. So usually setup and takedown's a little bit easier and quicker to refill. The biggest drawback in terms of incorporating task trainers into simulation is just that environmental fidelity. I think that you're just always going to struggle when you are taking the students out of the scenario they're in to move them over to a tabletop. It's just not going to flow the way of an authentic interaction, right? It is going to feel choppy. I think that sometimes it can be done well in terms of moving them over and that being built into the flow of the sim. But I think that we all know that being able to just have it kind of run full through is always going to be the ideal versus having to break that up. And then also, even if you do have that task trainer in the bed with the mannequin or the standardized patient, there are a lot of things that can go wrong. I remember specifically we did one with the IV arm and it was just super awkward in terms of it wasn't connected to anything. So that was the challenge, was that it was just very free floating. So being the standardized patient in the bed, and again, my arm's behind my back to feel like this is my new arm. It's not actually connected to my shoulder. So it's just kind of, again, it can be manipulated, it can be moved. My greatest fear was it just falling out of bed and having to be
happened a few times.
It's on the floor now. That was my biggest fear, was how do you come back from that? Because when those things happen, to then kind of remain in character and be this serious person makes it very challenging because it's clearly a funny situation. And so then to expect that students wouldn't laugh or wouldn't, come out of that, I don't think it's realistic to think that they, of any good-willing student, even if they're trying to remain engaged, that's a funny thing to have to overlook. And
what's that comedian's name? Nurse
Blake.
If you watch some of his parodies, it reminds you a lot of what
what can go wrong in terms of environmental fidelity.
Yeah, and especially when the IV one comes up, especially if you don't have a sim tech, because they're worried about putting fluids into the mannequins and things along those lines. Reskinning them is really hard. At least it has been historically. And so it is something where they're going to choose that option over having them start an IV and infuse fluids. There's all kinds, especially in medical school and stuff, they'll have them put in central lines and things. The other thing I would say to that is that it requires a really advanced SP to be able to react to what's happening as far as procedurally.
Yes.
If you think of a SP that's fairly new to the circuit, that may be too much to expect them to be asking questions and interacting because they don't really know what they're feeling. They don't really have a...
Well, because you're not actually... I remember when we did one that I think it was removing tegaderm from the IV arm. And when they were doing it, it was so weird because you are reacting... But, like, you're watching it, like, it's, because in your natural human instinct is that you're not going to necessarily be watching someone take a tegaderm off. If you're in pain, you're, that hurts, but you had to watch to see when they'd be ripping it because you needed to know when you were actually supposed to be in pain. Mm-hmm. And so, like, that just makes it, like, an uncomfortable situation where you're trying to make it realistic, but it's clearly not realistic to what's going on.
Yeah, exactly.
Yeah, I agree with that. And I think that that is a different element that I hadn't thought of. But it is true that reaction and response to the care being provided, especially in terms of urinary catheterization and things like that, if you are putting a task trainer and expecting them to react and respond, you have no idea what's happening. So again, you're doing your best, but you have no concept.
Hence why there are sensors inside.
I mean, but you're really trying to work off of the things they're saying versus being able to do it any other way. Right. And I think that standardized patients really do appreciate being able to have other elements a part of the sim. Like, I think they enjoy having the fact that
they
you
like
can
the
do
challenge.
It.
Mm-hmm.
But I do think that there are a lot of additional elements that come into it for that environmental fidelity, for it to feel like a fluid process, to make it realistic. So then moving on, do you want to move on to mannequins or on to VR?
Yeah, I mean, one story that I wanted to talk about with the mannequins was when we did the Code Blue simulation, where we had an SP that was having active chest pain, and when the nitroglycerin was administered, the SP, that was SP's cue to go unconscious, and they knew from the pre-briefing that they were going to move over to the manikin for the remainder of the simulation. Mm-hmm. So that is another form of hybrid, right? It's including SPs and mannequin simulation. Mm-hmm. So you can also think about that if it's an appropriate thing to do. I've done it where it's a code situation a couple of different times, but when you think about hybrid, that's another option. Hybrid is simply just combining two different modalities to make it more environmentally, the environmental fidelity to be more. So so let's go into mannequin based.
So I think with mannequins, that is the accepted modality. I think that is the widest used. Obviously, it was the earliest, adaptation of what we were using
in the US.
Nursing simulation.
In countries like the UK and Australia, actually SPs was the first modality. And EMS, they've been using SPs for forever.
But I think that concept of using mannequins is what predominantly people are comfortable with. I think that's the normal situation. And I think that people are beginning to diversify with what kind of tools they want in their tool belt. I do think that it's hard in terms of looking at mannequins because there is such a wide range. Like, if you are looking at the lower technology to the higher technology, I don't like to use the term low fidelity, high fidelity, because I think that is not the correct term, is that having more technology means more fidelity. I think that is a term that very creatively in marketing that was coined by the mannequin companies. So I'd like to consider it more technology based than fidelity based.
And that's in the literature too.
That's coming out more recently too, again, with this emphasis on fidelity and really kind of reclaiming that term. But I think that there is a wide range in terms of the lower technology mannequins. I mean, those are what we typically would use in skills. It's very challenging to use those low technology mannequins in simulation in general, especially if there are not other modalities being incorporated into that simulation. For those mid-level mannequins, I think that being able to have them in sim is, I think you can absolutely use them based off of the needs that you have inside of your objectives and your simulations and things like that. And then the higher technology mannequins, I think for nursing sim can often be too much technology for what is needed. I think that a lot of times there's a lot of additional components that aren't necessarily essential to meet the objectives of the simulation.
And I think that's been a common feedback that...
especially for undergrad. I should specify undergrad nursing.
Yeah. I mean, I think that was common feedback, and that's why the mid-fidelity or mid-technology programs came out, right? Or mannequins came out, is because there was times where you felt like you were paying for all of these additional feature functions
that you did not need.
But unless you had like a CRNA program or you had, you were doing anesthesia, it wasn't necessary. But again, the early inception of this, really went back to the whole idea of anesthesia, right? So the way that the CAE manikin was initially set up was always based on the physiology. And then with SimMan, two anesthesiologists created this difficult airway. They were from University of Pittsburgh, and they were trying to find a company to produce it.
Yeah.
And one of our board members, actually, David Broussard, his wife, he worked for Medical Plastics Technologies Incorporated, and his wife had to have emergency appendectomy and had a difficult airway. And the surgeon told him, or the anesthesiologist probably told him, but basically said, your wife has a very difficult airway. So if she ever has to go for emergency surgery, make sure that you are telling them that she has a difficult airway. Well, so he was trying to find, when they approached him about getting this incorporated, he was all for it because he had a personal experience, right? Now Laerdal ended up buying medical technologies or medical plastics, whatever it was. But Laerdal ended up buying them, so that everyone knows it as the Laerdal manikin. But so actually both of those mannequins came out of the idea of anesthesiology, intubation, you know, that kind of thing. So that you can see where that's all, you have to have a high fidelity piece to really be practicing.
High technology piece.
Sorry, high technology piece. I am definitely soaked in the industry, but you have to have that. You have to have a lot of technology in that to be able to do the anesthesia type things. So as nurses, we felt as though we don't need all of this, especially in undergraduate, which is where I focused most of my time. I don't need all of these things.
Yeah, I don't need difficult airway.
Right. I don't need it to be able to, you know, attached to a ventilator or anything like that. And so that's where really kind of the inception of this mid-fidelity manikin came out under the market. But just know that from the beginning, that's why it was all the bells and whistles. And I can understand why they would start with that based off of kind of historic knowledge. But as they moved forward, they came out with this to make it a little bit more palatable as far as price, because we didn't have to pay for, you know, all the different feature functions that required the higher technology.
Yeah. And I think that oftentimes people will see it as, you know, when we're doing presentations to talk about things, that in any type of way we are bashing mannequins. And I want to be very clear that there are time and places for mannequins. I think what our soapbox or what we're preaching is there's other ways to do it. This is the standard, and a lot of people have accepted this, like you said, that this is their only tool in their tool belt and they can't go beyond that. But I think what we're pushing is that there's other modalities, there's other ways of doing it, and just thinking differently. And I think that in some ways that does challenge the status quo of, you know, how some people run programs. But I do think that in our opinion, we're not saying get rid of the mannequins. We're saying add additional tools to your tool belt to be able to accomplish what you need. Because as a sterilized patient, what I will say is, I don't want to ever play an unconscious patient in simulation. That is not a good use of my time to lay in a bed with my eyes closed and being an unconscious patient. That is not a good use of anybody's time or energy. Because again, then at that point, it's very silly to be giving feedback from an unconscious patient. The patient's unconscious. They're not aware of what's going on. Like, they're not actually, you know, so that doesn't make any sense. And then over time, you know, I was a part of a lot of simulations where in the objectives, there was no objective about teaching or communication or empathy inside of it. It was very task-oriented based off the skills of the students. In those situations, it was not always appropriate to have a sterilized patient in those sims because I could sit there for 40 minutes and nobody would speak to me or talk to me because they were getting meds drawn. They were setting up the pumps. They were, you know, they had all of these other things that need to happen. And part of my feedback to the instructors was, they're not going to talk to me, and that's okay. Like, because again, that was kind of my stance, is like, they're not talking to me. They'd be like, well, that's fine because they need to draw up meds and that's not a part of the objectives. And it'd be like, well, if it's not a part of the objectives, I don't think that it makes the most sense that I'm in the room. I think that a mannequin can fulfill handing them a med and saying, here's the side effects, here's what's going to happen, you know, whatever. But I don't need to be there because I'm going to ask maybe 1 or 2 questions max, and we're going to move on. And at that point, being able to have, you know, a mannequin that you're not paying hourly, that you're not training, that you're not doing dress rehearsals with, is the better tool for that simulation to meet the objectives that are needed.
So I have a couple of emotional responses to that, but
Okay.
but the first thing I want to say is the reason that we could even consider in that situation having an SP is because our pool of SPs were not being paid.
Mm-hmm.
They were actually in a course.
Mm-hmm.
So just that's a caveat, because not everybody has a kind of an endless pool of SPs.
Sure, but I do remember when I talked to that consultant a few years ago with the SPs, and again, I don't know the extent of it. This was from one person. I did not talk to the SPs, but their opinion on it was almost we have to be in every sim, and if we're not, that's a problem.
Okay.
Adam just texted me and said to check that.
Yeah.
Yeah.
Thank you.
I think we need to redo that because you put your finger out.
Tried to tell her to wait.
Should we just go back?
Yeah, you can go back.
I don't know where to go back to.
I'll just say I have a number of emotional.
Yeah, go ahead.
Okay. So I have a number of emotional responses to that. But the one thing I want to say is that people that are listening would say, why in the world would you have that many SPs that you have the ability to have somebody that's, you know, in that situation where it's all skills oriented, or, you know, they have lots of things. But we were teaching a class, we weren't paying SP. So just to be clear, we had to reevaluate our own objectives because we got a little SP happy.
Yeah. But I mean, I will say too, though, that with talking to the consultant, she said, my SPs have basically come forward and are like, we need to be a part of every sim, or like, almost like, and again, this, I didn't talk to the SPs, I only talked to her, but kind of like, we're taking it as an emotional, like a personal attack that you're not including us. Like, she told me that they said they wanted to be a part of the unconscious sims, and that, like, basically as the instructor, as the person running the program, she didn't want to slight them in a way of like saying, yeah, no, you're not going to be a part of this. And then it became this like, well, should we be approaching it? Like, so I think sometimes there is this critical element of either the SPs band together and feel like they need to be a part of every sim, or again, you're not paying specifically for those SPs, so like, why not include them? But I do think that coming from someone who, again, my background is standardized patients, I have a CHSE, so I can kind of see it from a lot of different sides, but looking at it objectively, it is looking at it in terms of what is worth my time and energy to put into the training, the preparation, the character, and all of these different elements, and making sure that it is elevating the sim, or it's the right tool in the toolbox, right? To be able to include it. And I do think that sometimes people lean more towards using mannequins than they do standardized patients. I think that's the natural lean. But I do think sometimes we can lean more to using standardized patients when the mannequin might be appropriate, especially based off the objectives. And I think sometimes you have to get a little bit removed, because I think we kind of favor one tool or another. I do think that can happen.
Absolutely.
But trying to look at it objectively, and I will just say, from one standardized patient to other standardized patients, it's not a personal slight if you're not used in every sim. It's okay to have other sims that you are not a part of. And sometimes maybe it's better for you to be the family member of that unconscious patient.
That's what I was going to say.
Or, you know, like maybe it's better that you are, you know, like adding, but sometimes, especially in terms of like thinking about med administration or getting the pump set up and things like that, sometimes your level of learners aren't also ready to deal with an upset family member or an upset patient or whatever it is. So just sticking that objective in there, sometimes now you're making it too hard because you're asking them to do all of these different components, plus now dealing with that live person.
Yeah. I mean, my own personal experience is that when you get to the point of doing some of those med surg sims, that if they are in a clinical experience, they're going to have family members that are going to be asking them questions. So if you're talking fundamentals, or you're talking some of the very early on before they get into a lot of the clinical experiences, I can understand that. Yeah. But at the end of the day, being able to talk to concerned family members is a skill that needs to be developed. So
it has to be a part of the objectives. I think that's the part where things can get lost, is that if it's not added into the objectives and you're just now like, and we have a family member, let's ask Susie down the hall to come in and play that family member, and it's not a part of the objectives, the pushback that I always got was, well, we don't really care about that in this sim, or like if they don't talk to you, it's fine because it's not really an objective. And I think that's the part that it's just like, if you're gonna include that, and I agree with you that if they are going in the clinical setting, they will be expected to answer questions. They will be expected to interact with people and need to learn how to do both things at the same time. But it's got to be in the objectives.
No, I agree with you on that. But from, as a simulationist, basically, like, I would always include it in the objectives. That's just, and it just may be my own personal bend, but it is just seeing how realistic, or how, you know, how sometimes that can really mess you up. I mean, there's been times where, you know, they've been doing clinical rounds on a patient, and it's a woman in her, you know, let's say 60s, and next to her is sitting a man in their 60s, and the clinical team is going all through this patient's history, yada yada yada, and it's the neighbor.
Yeah,
and
it's
not her husband or, you know, brother or whatever. Yeah. Like, nobody's taken the time to check that kind of stuff out. Yeah. So again, it's just really important that they understand the dynamics and how you address that, where, you know, there's a million things, and there's a lot to learn in healthcare. But it is something where I do think there's a time and a place, and no matter what, if it's not in the objectives, if there's no communication, no education, no assessments that are necessary, you know, that was one of the things when we were at the New England Sim Summit that the individual from Yale said, I can't remember her name, I'm so sorry, but she said, you know, when you need nonverbal reactions and you need, you know, the patient to be demonstrating certain things, especially assessment, like think of like stroke patient, and they need a slurred speech and, you know, deficit in their, you know, weakness in their one side versus the other. That's all stuff that is way more approachable, or things that are emotional, where like they're doing some stuff with pastoral care there. And so having a mannequin is just not the same, you know, doesn't have the same energy in the room. So, but I will say that for mannequin-based simulation, anything that is unconscious, that is very highly task-focused, does really warrant a mannequin. The other big one is pediatrics, right? That's kind of another big place where mannequin simulation can be appropriate.
So on the flip side of that, I think that there's also the limitations that come with incorporating mannequins in terms of, you know, I didn't realize this, but in their user manual, it says that they should not be moved out of the bed once they're placed in the bed.
And we've had some personal experience with breaking of the neck.
Yeah, I think that it was like, once I heard that was in their user manual, I was like, yeah, that tracks, because we've not had great experiences with that. But I do think that there's...
And as a caveat, we don't know every single one. We just know that the ones that...
Yeah, there's certain ones. There's certain ones, right? But in those terms, I think that does make it very complicated as a simulationist, where you are not able, or you're not supposed to be moving them out of the beds. There's the obvious limitation where the patient can't get out of the bed and can't move. I think that there's been a lot of energy and effort in terms of trying to make mannequins have more human features or elements. Like, again, they've been working so hard on making this mannequin be able to move its hand up, to be able to do a handshake. And when we talked to Crystal Farina, she was like, I've done that at conferences every year. She's like, and it's not the same thing as shaking somebody's hand, right? So I do think that there will be these limitations that happen, you know, making mannequins cry and things like that. It's fine until the mannequin breaks, and then it can no longer cry anymore, right? And then now what do you do for that sim, because you don't have that element? But I do think that there's the appropriate times and places, but I do think that those physical limitations it is still not the human body. It is still not a human person. And I do think that you're still going to struggle if you're solely relying on the technology to make the facial expressions, or to, you know, show sepsis and things. Like, I just think you're going to have a harder time when it is that mannequin.
Nonverbal communication is what I think 80 or 90%.
Yeah.
And
that is always going to be a limitation, because they can put so much money and effort into making those mannequins more and more realistic, but it is still going to it's still never going to be human. It's just not. You're always going to lack that. And I think that really impacts, you know, what your objectives are and what you want to accomplish.
And quite honestly, the more technology they put into it, the more expensive it is, right? There's a lot of research and development that goes into it. So, you know.
True. Yeah.
How much can you bear as far as cost?
Absolutely. And then looking at the pediatric side, this is a more controversial topic inside of simulation. Even if you look at it from, you know, internationally, Australia has a lot of literature that's come out. The UK has had a lot of literature come out. The US, I don't think as much, but there's a lot of opinions here in the US. And I would say that this is one that I feel a little torn on, and I think it definitely depends on the situation you're in. But I've heard several times people say, oh, well, if you're doing pediatrics, you'd have to use a manikin. There's no other choice. And in Australia, one of the sim centers that I visited in Melbourne, they had a lot of pediatric synchronized patients. They had a whole pool. It was something that like they were very confident with. That was what they did, was that they had children. I think it was from about 5 to 15. They had a lot of pool, and they were all child actors. But the important part here that I think is often overlooked is there is so much energy and effort that goes into having these children actors.
Yeah, I was going to say.
Like, if you think about, like, a movie set, if you're going to film a movie now with children, there are so many components, from legalese to, you know, how long they can work, child labor laws, you know, the emotional toll that it can take. But they have someone designated to their child standardized patients that is solely there for their, you know, to check for the child labor laws, to check for the psychological and physical safety, to manage the parents of the children. And it is built into it. And when you talk to them, when I was touring their center, it's like they talk about it like, yeah, this is the easy, like, of course, yeah, you just hire someone and they manage it. And like, yeah, no, what do you mean? And I think that sometimes that is not necessarily realistic of all simulation programs, to think that they can just hire someone to manage, you know, just their pediatric sims. You know, it's kind of like thinking of hiring someone to just manage your maternity sims or your med surg sims. So it feels very complicated, but I think here in the US, a lot of people just steer clear of it. Or on the flip side, which personally I think is more dangerous, is a lot of people will just bring in their young children, put them in a bed, and be like, they're the patient for today. And I think that having children who are, you know, their parent works in sim or whatever it is. Now, again, speaking as someone who personally went through this, I was 16 though, and I had already had acting experience, and I knew what I was getting into. I was given training. I went through the full gamut of what needed to happen, but I was 16. I think it's very different when you're bringing in a 5-year-old, putting them in a hospital gown, telling them that they're sick, and then expecting them to run through sim. And I think that that's the part that gets dangerous, is that if we are just kind of viewing this as, oh, it's no big deal, we'll just throw somebody in, that can be very traumatic to children for not being able to separate the realities. So I think that there's a lot of different angles here. I think the positives of obviously having the pediatric manikin is that you don't have to worry about including a live person. But as a standardized patient who's done a lot in terms of being the mom in the room, it does feel very awkward to have this child that you're supposed to love and show, you know, and all of this, and you can hear the mechanics of the head turning, you can hear the mechanics of it, you know, moving. It's a little creepy. It's a little Chucky doll kind of thing. Like, it's scary. So I do think that there's elements of being aware of the psychological safety of having a real human, having the limitations of the technology of the manikin, and then I think finding the appropriate middle ground. And I do think bringing in 13-year-olds, 14-year-olds, or even having 16-year-olds who look younger, playing the role of a 13-year-old and things like that, all of those things are possible. I played young patients all the time when I was 16 because I could get away with it. And having that, I think, is also an added benefit. But when you're talking 5, 6, 2, to think that you're going to be able to bring in a real child, I think that it's just considering the potential damage for the potential reward and weighing that.
Yeah. I mean, I think obviously they have a very sophisticated system, and they have, whatever site that you're referring to. Mm-hmm. I know there's a site in Utah that does a lot with pediatrics and SPs. It's almost like, I remember Bethany, my other daughter, she was talking about in theater, if they have a sex scene or have some kind of scene, there's an intimacy coordinator or something. It's the same kind of idea where you definitely need somebody that's really
I think that's the part that I would want to emphasize here is anyone who is thinking about bringing in children, like, understand that people don't just take children and plop them into a movie and say, okay, go ahead. Like, that's not, there's so much that goes behind the scenes. There's so much additional work that happens. There's so much technical pieces that go into it to, again, I don't think that always happened. If you think about like Wizard of Oz things, I think there was a lot happening in those days that were not kosher. But in today's day and age, there's so much behind the scenes that we don't see. And I think sometimes it's just this element of like, oh, well, they do in the movies, why can't we do it here? And just understand that there's a lot that goes behind that. And it doesn't mean that it's impossible, but it means that there's a lot of pieces to it. And I think sometimes it's just better to use the mannequin to avoid all of these additional components that would be expected of you now that you're kind of taking this on. And quite honestly, the same way that ASPE put forward the standards of best practice with standardized patients, I do think that if pediatric patients started to become more prevalent, I think there would be different standards. Yeah. If you're under 18, I think that there would be a different level of expectation and code of conduct in a way of approaching it when they are under 16 years old. But
I know ASPE released one for the people that do the genital teaching exams. Mm-hmm. So there's a specialized thing that, so I could see the same kind of, I think I could see it passing over into the pediatrics as well. It's a good point.
Yeah. All right. So moving on to VR and AR. So this is really, again.
Yeah, we kind of killed SPs and mannequins at the same time. So.
Yeah, we really did. We kind of approached that kind of a double it. Because I do think that in a way there can be a lot of harmony there of including both of them in that hybrid situation. So I do think that there's a lot of ways of being able to merge those two together and figuring out what's appropriate between the two. But no, I agree. I think we chatted about both of them. So going on to AR, VR, I know that you recently had a conversation with Dawn from
Oxford
Medical Simulation, which really focuses on the AR, VR side of things. So do you want to chat a little bit about what that conversation was about?
Yeah, and I think also, I've talked to several people about AR, VR, just because it is kind of the up and coming and everyone's, looking at the technology and watching it develop over time, which is really kind of cool. But the other really big impactful conversation that I had, or it was actually like a seminar that I attended. So I was presenting at the Mayo Clinic, but one of the other individuals, his first name was Eric. I can't remember his last name, but he is definitely an expert. He did his PhD on AR, VR. And he actually came up with a kind of a whole appropriateness of where AR, VR can be used. And it was very similar to my conversation with Dawn as well. But AR, VR is a really great preparatory work. Mm-hmm. So if you think about, like when you go to the sim conferences, they're, doing operating room things or even like cesarean sections and things along those lines. And so preparing the room, or, not every sim center has an OR that they can practice in with all of the different trays and all of the different things. So having an AR, VR system where they can, move the things, again, I'm not an OR nurse, so I don't know very much about it, but just that they can function within that role based off of what you're trying to teach them within their program, and preparing them is really a great preparatory piece. He talked a lot about, if you actually have the actual tools that they would be using. So if you think of the Da Vinci surgical robot, or I don't know exactly what they call it, but the Da Vinci tool, having someone who's getting ready to do a surgery for the first time, practicing with actually using that device the way that it's supposed to be. And there's like a lot of stuff out now with endoscopy or colonoscopy or whatever it is. So they're actually like using the actual physical pieces of this, but visualizing something different. There's a lot of benefit to that, right? Where you're preparing them for a difficult or complex skill or task. And then the other place where they talk a lot about where it's really, really good, both Dawn and Eric talked about where it's really good, is warming up. So if you think of a surgeon who's maybe they've used the Da Vinci tool for this type of surgery 100 times, so, heart bypass surgery. But this morning, before the first surgery, they go in an hour early and practice on the Da Vinci simulator. They're warming up. It's kind of like a tennis player, like just, let's just go through. And you can put those high stakes, low volume simulations, right? Where, an artery gets nicked or something happens, and you can, create that visually within the Oculus devices. When we were at GW, Crystal had just purchased some AR/VR, and I asked her about people getting like that motion sickness, because that's something that's come out in the literature.
Well, that's frequent with the VR. So AR is usually not having that motion sickness, because you're, again, just augmenting the reality of having something that comes up. But the VR is the full encapsulation where you are.
Right.
And so that is more common with the VR.
Yeah. But what she said is that they can project it on the screen, which at that point I assume then it is more like augmented reality, where you're not seeing it through the Oculus, but you're seeing
But
it.
the augmented reality is more supposed to be like, if you think like Pokemon Go, where you're seeing it through the screen and it's one thing is coming up. And so it's just kind of looking like, so if you're looking at it through your phone and it looks like there's a Pokemon character running around the room, but it's just that one element. So with it projected, I don't really know exactly what that term would be.
I don't know what you would call it.
But again, with the virtual reality, it's just supposed to be that it's more of the whole setting.
But again, there has been a lot of discussion about whether people get motion sick with it. So they have to come up with an alternative for that.
Yeah.
Dawn also mentioned within her particular product is that they have the ability now to do multi-patient simulations. So, if you think of like you have a 5-patient assignment now, and you're individual, because like typically in sim it's 2, 3, 4 people that are going in there. Now you're by yourself and you're managing all of this. It gives more of a reality of what's going to be like when they're actually doing care. Again,
and I think it's less, I think that's also like the appropriate first step in that, kind of what you're talking about with like that warm up, is throwing them into a room with mannequins and sterilized patients and kind of like, a triage type of situation. If they started with doing that in a VR setting of learning of how to triage and learning how to prioritize and all of these different elements, that's also going to be that kind of first step. And then it's like, okay, you're practicing that in this virtual setting where it's a little lower stakes. Now we're going to be able to put you in a scenario where, again, you have multiple mannequins, multiple sterilized patients, things like that. Now let's use those same skills that we've been practicing in that VR world now into the real life.
The only struggle with that is that it's very typically pretty difficult to get 5 patients in a sim room, right?
Absolutely.
Two's probably max. And typically because of time, you want 2 or 3 people in there. So you might have one that's the tech and one that's a charge nurse and one that's, the primary nurse or something. And you can recreate it that way. But where AR VR shines is they kind of have their own individual performance that they can check on. But there are limitations. The technology isn't quite there yet as far as tactile feel and, the
graphics.
There's some limitations with that. But it is, again, that's really where, if you look at what Eric's work, and I should probably know his last name and I don't, I apologize, but it really is focused on, if you think of preparatory before they're actually doing clinical care or they're doing simulations, and then also with reinforcement afterwards. So if you think of, if they don't typically get trach patients on a unit and now they're going to get a trach patient, maybe eventually there might be something that they could use as a warm-up or something like that.
My difficulty with the AR VR is, in some ways, I think part of it is the marketing of it, but I have a hard time when it's being marketed as, this is a cheaper, faster way of doing sim, because what they advertise is you don't have to have someone who watches, you don't have to have an instructor who watches the sim, you don't have to do a debriefing, and basically this is all a self-contained thing. And they do a cost comparison between, if you were to purchase a mannequin, need a facilitator, here's the cost of that, here's what the cost would be with VR without needing that. And I do think that trying to compare those two things as, here's a cheaper, faster way of doing it, in my mind, it comes back to that like silver bullet. There's no easy way to just make this where it's going to be, no money and super fast to get through, because I don't think the students are getting that same experience if they don't have a facilitator. The whole point is, we know that they have 80% of their learning happens in the debriefing. So if we just completely, entirely skip that step, I don't think they're going to gain the same knowledge. I agree with what you said in terms of a warm-up and also kind of like solidifying concepts and things like that. And I think those are great technologies to use that. But I don't think that it can be compared apples to apples in terms of a full-blown sim, with a facilitator, with other peers involved, and again, learning from each other and then going into that process, because I think it really does, in some ways, when it is compared apples to apples, I think in some ways it does cheapen what we do in sim, because it's saying, oh, well, why do you even need a facilitator? Let's just why even have a sim lab team? Let's just move all into this and then call it a day because it's cheaper and faster. And I think there's pieces for it. And like I said at the beginning of the episode, I think there's a place for all modalities in terms of what their strengths and weaknesses are. But I really don't like to compare it apples to apples to other sim, because I do think that then you're lacking the facilitator knowledge, which I think is also a huge piece of it.
100%. I would agree with you. And that kind of goes back to the whole psychological safety and, you know, all the different aspects. If they don't know what they did incorrectly, or if they're not, you know, if they're not being guided by a professional, that does lead to some challenges. You know, there's ways that they have looked at debriefing, and I talked to Dawn about that as well. But I do think that there is huge benefit to, you know, the idea that we're going to go through a debrief, you know, utilizing a debriefing model. They've just gone through the simulation. Now let's talk about it. And reframing their thoughts and, you know, allowing them to see where potentially they have room for growth or opportunity. And I think that at the end of the day, you know, the idea of reducing burnout, you know, preparing them the way that they need to be prepared for clinical, it is going to involve all of the modalities. And at the end of the day, there's no silver bullet, as you mentioned, there's no panacea, and you have to look at your objectives, and you have to look at your level of learner, and you have to make the best decision with the modalities that you have at your fingertips. You know, I think right now, people that are kind of looking at that newer technology are early adopters, you know, and they're, you know, that's not available in every simulation center, but it is something that is out there now as an option. You know, we probably, I don't know, 6 or 7 years ago now, we visited California Baptist for the first time, and they had an immersive room where their sim techs put this amazing, you know, like it was like a rainforest when we went in. It was just stunning. You know?
But that's the part to me that's where I struggle with, is they have these immersive rooms at Cal Baptist, which again, it is not VR. You're not wearing goggles. You don't have any special technology. It's projectors on the wall. It's different sound equipment. They've used a lot of tactile things like putting mulch on the floor so that when you're walking, it doesn't feel like you're just walking across a smooth surface, to make it feel like you're outdoors. I don't necessarily know how they would involve that. But then you have the immersive rooms that are sold by Echo, where it's kind of that blow up room with just the projectors. And to me, I'm like, well, those two aren't the same thing, because there's one that has the mulch on the floor, and like all the different components, one that's kind of more of just a projector screen in a room. And I think that is something that, as a newer industry, you know, for healthcare sim, that we are still figuring it out. We're not, you know, automotives, like, right, we haven't been around for hundreds of years. We're still figuring out these definitions, and we're still figuring out where do things fit and where do they go. And I think some people disagree. I think some people think, you know, oh, this belongs with this, or this is the same thing. And again, I think that those types of technologies, I do think more people will move towards these rooms. Again, in theater, you know, we call them black box theaters, where they can really be moved and changed into all of these different things to meet the needs of what, you know, that theater wants to do. And I do see simulation moving towards that direction. I think more and more people are starting to include that, but it really doesn't have a clear definition or a clear modality at this point of what it'd be considered. I don't know if it'd be even considered a modality. Maybe it'd just be considered an environment. I don't know. But it is really interesting to see how things grow and change over time. You know, for us, we were very clear to see that there is a gap in the market of needing wearable simulators. So really that was taking the benefits of the task trainers and, you know, the technology of the mannequins, and then the human element of the standardized patients, and then being able to merge that with these wearable products that were designed to be worn, and that have haptic feedback inside to cue the standardized patient. And there are different ones that we would also consider wearable simulators. So if you think of the cut suit, if you think of ventriloquiscope, things like that, there are other ones that are...
Ventriloquiscope is just a stethoscope. It's cardionics that has a...
The shirt. But I think that those pieces like ventriloquiscope has with the augmented, you know, stethoscope, I don't really know where that fits. Mom and Natalie, it's a wearable, but I wouldn't necessarily consider it a simulator, because there's really not any technology that's inside of the product. So there are still kind of these, I would almost call them outliers, where we've really coined the term wearable simulators to define something that is wearable and has technology built in. But there are other wearables that don't have technology built in, and those really kind of fit in a no man's land at this point of trying to figure out where these definitions live and thrive and things like that. And to create new categories for every product that pops up, I don't think is necessarily feasible. But when you do start to see it more and more, it does start to expect, you know, some sort of categorization.
We did our best to attempt to categorize them in the Defining Excellence in Simulation chapter, because it's such a broad variety. So broad. But even if you think of like simulated thermometers and blood pressure cuffs and pulse oxes, like where do they fit, right? Yeah. They're not really a task trainer, but we covered it in the task trainer chapter. And again, lots of really good use cases that we offered in that chapter. So again, I encourage you to read it if you have it, or, you know, check it out of your library if you can get the interlibrary loan. But I think that at the end of the day, our main message is there's multiple modalities and multiple opportunities for using tools in your tool belt. If you don't have the modality where that particular simulation would fit best, consider modifying the objectives of the simulation to fit in with what the tools that you have within your tool belt.
And the other thing that I think we've talked a lot about is hybrid sim. And I understand that may not always be the easiest based off of what your limitations are. But I do think hybrid sim and merging a lot of these modalities together to create an authentic experience is usually always going to be the ideal. Is it always possible? Probably not. But I do think in terms of being able to merge multiple modalities is often, and I think that's where we naturally lean, is usually into hybrid, because usually it's like, well, I want this piece and I want this piece. Let's figure it out together.
That's how Avkin got started.
Yeah,
for sure.
Let's make it work. And I think that's great. But I do think that in some ways it is people kind of re-looking at their sims and making sure that whatever those objectives are and whatever they want it, what they want the outcomes to be, really assessing the tools that they have. The other thing I just want to do a quick shout out before we end here is there is usually times that we go through people's sim labs and we'll do tours. And so often I hear people say, oh, that stuff has been on our shelf for years and we don't touch it, we don't use it. And those are the kinds of things that I really encourage people when you're coming into a new sim center or just refreshing things, look at the tools you have, because I think there's a lot of times that things are just on the shelf and you don't even realize you have it. And maybe you started a new sim a few years ago and you didn't realize you had this, but then now you can reassess and see, oh, this really is the best piece. Those are the types I just encourage everyone, like, dust the stuff off your shelves, take a look at it, figure out really what it is, and challenge yourself to make sure your sims are really using the proper tools that you have to get the most out of them. My other word of advice would just be, there's a lot of consultants in the world of sim, and a lot of people who are willing to kind of just chat about things in terms of what's out there. Chat with some people about what other tools they have in their tool belt of what they use at their sim lab, because I think a lot of times we're not great at knowing everything that's in the industry, especially if we don't have budget to go to IMSH and Anaxel and all these other places. If you're not able to really get out there, you don't really know what you have available. But talking to some people in your area or your sim team, or people who are local to you, if you have a sim group or something like that, there can be a lot of understanding that there are a lot more things out there, and kind of keep an open mind to what that could be. Yeah.
I would say if you're new to simulation, do a few tours.
Oh yeah.
Do a few tours, you don't have to spend any money. Just contact, a couple of the other sim centers in your area and go see what they have. We've done tours all over the country, and there are some amazing sim centers. Yeah. And there are some more humble sim centers that are still doing amazing things. So take a minute to look around.
And get really creative. I think that that's the other piece there, is there's a lot of people who get really creative with what they do to meet the objectives that they have. I think us in sim, we are able to really get our hands dirty. Exactly. We're able to really figure it out. And again, we appreciate you guys listening. I'm sure that we could have talked a lot more about different modalities. There's a lot more we could have covered here. But again, we want to just keep this kind of concise, high level, keep it simple. So we appreciate you listening. Any questions, leave them in the comments, and we'll see you guys soon.